Welcome back to the deep dive. Our mission here is to take these just massive stacks of complex sources, overwhelming data sets, and often intentionally confusing systems, and really break them down.
Break them down into something coherent, something you can actually use.
Exactly. And today we are tackling what is, I think, maybe the single most complex, expensive, and frankly, emotionally charged system in American society. We're talking about healthcare.
It really is. It sits right at the center of American life,
Yeah.
and mostly because it has this profound paradox at its core.
A paradox. How so?
Well, you have a nation that, on one hand, houses the world's leading medical technology. We have groundbreaking pharmaceutical innovation, elite medical schools. I mean, the best care money can possibly buy.
Right, in theory.
In theory. But then you zoom out and you look at the national scale, and compared to every other developed nation, our health outcomes are significantly poorer.
Yeah.
And access to that great care is far, far lower.
So excellence for the few, but systemic failure for the many.
It's a paradox of incredible innovation at the top and just pervasive failure at the system level.
Okay, let's unpack that right away. Let's define the stakes for you, the listener. The sources we went through are, and I don't think this is an exaggeration, chillingly clear on this point. It doesn't matter what your income is. It doesn't even matter if you have that insurance card in your wallet. The single most pressing financial worry for American households is an unexpected medical expense.
That fear is constant. It's pervasive.
And that fear, you argue, really defines the entire system.
It does. It's why we call it the labyrinth. It's this high-cost, low-efficiency structure that's so complex. Our sources show that half the population can't even navigate it successfully.
So our deep dive today, it's ambitious. We're going to trace the path from the very fragile, compromised birth of the U.S. public health system back in 1965.
Right, with Medicare and Medicaid.
And then follow it through this relentless, decades-long political project to privatize those public pillars. We're going to examine why movements for universal care have just repeatedly failed.
And finally, we have to look at the present. This radical policy shift, the 2025 OBBA, the One Big Beautiful Bill Act, and the truly catastrophic future it projects.
We're looking for the fault lines, the structural cracks that were there from the beginning that led us right here to this current fiscal cliff.
That is the mission. We have to understand not just what happened, but the mechanisms that were put in place decades ago that pretty much guaranteed the crisis we're facing today.
So when we talk about structural failure, it can sound so abstract, like a problem for policymakers in Washington, D.C.
Right, it's just numbers on a page.
But the data you pulled shows this is a crisis measured in, well, in specific human hardship. It's not just a balance sheet. So what are the stats that really capture the reality of these cost and access barriers today?
I think the thing that stands out immediately is just how widespread the struggle is.
Yeah.
It really confirms your point that this is not just a problem for people who are uninsured. Recent surveys from the Kaiser Family Foundation, the KFF, they show that roughly half of all adults in the U.S. struggle to afford health care.
Half.
Half. That's 100 million people facing financial stress just to stay healthy.
Wow. And what does that struggle actually look like? I mean, what kind of real-world decisions are people making? Because it's one thing to say you struggle. It's another thing entirely to, skip care you need.
And the sources show a direct, undeniable line from that cost pressure to what they call medical avoidance.
Medical avoidance.
About 3 in 10 adults admitted that they either deferred or skipped necessary medical care for themselves or a family member in the last 12 months. And the reason was always the same: cost.
And that includes insured people.
Absolutely.
Yeah.
This includes people who have insurance, but they're facing these incredibly high deductibles, which essentially make the first few $1,000s of any treatment an out-of-pocket decision.
So the deductible becomes this massive gatekeeper, even if you're paying your premium every month.
It's a wall. And the kinds of care people are avoiding aren't, optional. We see 36% of adults delaying routine but vital dental care because of money. And worse, 21%, 1 in 5 adults skip filling prescriptions entirely.
1 in 5. So they go to the doctor, get a diagnosis, get a prescription to treat it, and then just walk away from the pharmacy empty-handed.
They make the calculation that they just can't afford the medicine they've been told they need.
That is bad enough. But when I was reading the sources on medication rationing, that's a whole different level of desperation.
It's deeply disturbing. 1 in 7 adults report actively rationing their medication. This isn't just skipping it. This is taking matters into their own hands.
What does that mean, rationing?
It means they're splitting pills in half, they're reducing their dosage, or they're trying to stretch out a 30-day supply to last 45 or 60 days. All of it, of course, against explicit medical advice.
Just to save money.
Purely to save money. And the risks are they're massive. You could be risking a stroke, a heart attack, permanent organ damage, just to save a few dollars on a monthly refill.
And you noted this burden isn't spread out evenly across the population, is it?
No, not at all. This is where you see the systemic failure interacting directly with existing socioeconomic vulnerabilities.
Okay.
The practice of rationing is disproportionately higher among low-income households, which makes sense. It's also higher among young adults, who often have those high-deductible plans, but don't have savings.
And one other group stood out.
Yes, Hispanic adults. It's clear the system is not failing equally. It is crushing the most vulnerable segments of the population first and hardest.
So if the system is designed in a way that forces people, insured people, to skip necessary care, it's not just failing to prevent health crises, it's actively creating financial crises.
That's the perfect way to put it.
Which brings us to debt. How deep has medical debt seeped into the American economy?
It's pervasive. As of very recent figures, a staggering 41% of U.S. adults carry some form of medical debt.
41%.
And we need to be clear what that debt includes. It's not just the bill you owe to a doctor's office.
Right.
It covers credit card debt you used to pay those bills. It's money you borrowed from family or friends. And it's debt that has already been sold off and is now being pursued by collection agencies.
So nearly half the adult population is living with this shadow of medical debt.
And this isn't some minor peripheral debt. Medical debt is consistently cited as a leading cause of personal bankruptcy in the United States.
A leading cause.
It's a primary mechanism that pushes middle-class families, people who did everything right, they had jobs, homes, insurance. It pushes them into poverty. The system itself generates this massive financial loss in its own wake.
And a huge part of that debt comes from the sheer complexity that allows the system to trap people. I'm talking about the infamous surprise billing phenomenon.
Yes.
You do everything right. You go to an in-network hospital, you check your plan, and then weeks later, you get a bill that just crushes you.
The complexity is the weapon here. Half of all insured adults freely admit they don't fully understand the scope of their own coverage.
I am one of them.
I think we all are. They don't know what their potential out-of-pocket costs will be for a major procedure. And surprise billing preys on that ignorance.
So walk us through it. How does it work exactly? For someone who hasn't had this happen to them, it seems like it should be impossible.
Okay, so imagine you go to an in-network hospital for a surgery. You did your homework, the hospital is covered.
Right.
But during that procedure, a specific person, let's say it's the anesthesiologist who is subcontracted by the hospital, or a specialist who is called in for a quick consult.
Okay.
That one person is considered out of network.
Even though they're inside the in-network hospital.
Exactly. And because that specific doctor or their group wasn't contracted with your insurer, they are legally allowed to bill you, the patient, directly for the full, non-negotiated, and often wildly inflated cost of their services.
Wait, so the hospital is in network, my surgeon is in network, but the person who puts me to sleep before the operation even starts might not be.
Correct.
And I, the patient, under anesthesia, am somehow responsible for checking the network status of every single person in the operating room. That sounds completely insane.
It is an unreasonable situation, and consumers are completely unprepared for it, and the sources confirm this is a direct path to those crushing, bankruptcy-inducing jets we talked about. It's like the final, horrible administrative joke the labyrinth plays on you.
So we've got insured people rationing medicine and going bankrupt. This has to bring us back to the foundation. When Medicare and Medicaid were created in 1965, why didn't they solve these problems from the start?
Well, to understand the crisis today, we have to look back at 1965 not as this moment of total triumph for universal care, but as a moment of profound and, I would say, system-defining political compromise.
It was fundamentally unstable from the very beginning.
Exactly. Because of the compromises required just to get it passed into law.
And the historical context here is so important. This wasn't a new fight in '65. We're talking about a political struggle that goes back decades before that.
Oh, absolutely. Early attempts at some kind of comprehensive universal coverage. President Franklin Roosevelt wanted it. President Truman definitely pushed for it. They were completely shut down.
By who? What was the roadblock?
The roadblock was the American Medical Association, the AMA.
In the mid-20th century, the AMA was this immensely powerful political and lobbying force.
And they had a very effective strategy.
A brutally effective one. They derailed those early attempts by using what we now recognize as, frankly, Cold War propaganda. They aggressively and very successfully labeled any push for universal health insurance as socialized medicine.
Which played directly into the public's fears of communism and government overreach.
It was the perfect political weapon for the time.
But by the 1950s, something had to give. The poverty among the elderly was just too extreme to ignore. It was an undeniable crisis.
Precisely. As seniors started living longer, they were outliving their savings. They were facing astronomical medical bills with absolutely no safety net.
So the politics had to shift.
When that crisis became undeniable, the political strategy had to shift away from the AMA's main point of opposition. The focus narrowed dramatically. It went from universal coverage for everyone to specific categorical aid targeting just two groups.
The elderly and the very poor.
The elderly and the very poor. That strategic shift is the key. It led directly to the 1965 Social Security Amendments, signed by President Johnson, creating this two-pronged system: Medicare for the elderly, Medicaid for the poor.
And this is where we get the famous three-layer cake structure.
Yes, a structure largely designed by the very powerful Ways and Means Committee Chairman Wilbur Mills, and it is fragmented by design.
Okay, so let's break down the layers. Layer 1.
Layer 1 is Medicare Part A. This is the hospital insurance.
This seems to be the one part that most closely resembled what reformers originally wanted, a social insurance model.
It is. It's the most fundamentally progressive element of the whole thing. Part A is funded through a mandatory payroll tax.
Meaning we all pay into it our whole working lives.
Right. And it covers mandatory hospital services for all Americans 65 and older, regardless of their wealth or their health status. It's pure social insurance.
But then we get to Part B. This covers the doctors. And this is where the political compromise basically cemented the cost problem for the next 60 years.
This is the Faustian bargain. Part B, which covers doctor visits and outpatient services, was the critical concession made to the AMA to get them on board.
And it was structured completely differently.
Completely differently. Not as mandatory social insurance, but as a voluntary insurance layer. It's funded by a mix of premiums paid by the beneficiary and general government revenue.
And the crucial detail, the one that's so often lost in these policy debates, is how the doctors got paid under this new system.
This is the poison pill, the payment mechanism. Part B was explicitly designed to guarantee that doctors and physicians would be paid their usual, customary, and reasonable charges, UCR.
What does that mean? Usual, customary, and reasonable?
It means the AMA had successfully blocked any attempt by the government to establish a fixed or controlled fee schedule. There would be no price controls.
So doctors were essentially allowed to set their own rates, and the government was structurally bound to pay whatever the prevailing market rate was.
Essentially, yes.
Yeah.
By building that guarantee right into the law tying government payments to whatever the market would bear, rather than a predetermined controlled price, the 1965 compromise built structural, unchecked cost inflation directly into the system from day one.
It ensured costs would always go up.
Always.
Yeah.
Because there was no mechanism for price negotiation or control built into the Medicare payment structure.
Did no one at the time see this coming? That this would lead to just an explosion in costs over the decades?
Oh, economists who were arguing for a single-payer system absolutely projected this. But the political reality was that this concession was the price of admission. It was the only way to break the AMA's opposition and get the Medicare program passed at all.
The priority was getting coverage for seniors, not long-term price control.
That's right.
So Part B, guaranteed inflation. Now let's look at the third layer of the cake, Medicaid, the program for the poor. Why was this layer inherently flawed from the get-go?
Medicaid had a completely different but equally destructive design flaw that was rooted in American federalism.
Okay.
It was based on expanding an existing state-level program called CURMILS. The inherent problem is its reliance on matching funds.
Meaning the cost is shared?
The funding and the operation are shared by the federal government and the state governments. The federal government provides a big match, but the states ultimately control the benefits, the eligibility criteria, and all the administration.
So the level of healthcare you get if you're poor in America is dictated almost entirely by the politics and the budget choices of your specific state legislature.
That is the precise consequence. We don't have one uniform national safety net. We have 50 different ones.
And a poor person in a politically conservative, financially strained state might get minimal benefits.
While a poor person in a more progressive, wealthy state might get comprehensive coverage. This structural fragmentation means the safety net is just riddled with holes, depending entirely on your zip code.
And to make this already unstable foundation even shakier, our sources note that private industry was brought into the fold immediately.
Yes. This essentially created the blueprints for future privatization decades before anyone was even using that term.
How did that happen?
It was really a decision of logistical and political convenience. Private insurance companies, like Blue Cross Blue Shield, were immediately hired to act as fiscal intermediaries.
Fiscal intermediaries, what was their job?
Their job was simply to process the claims and pay the providers, the hospitals and doctors on behalf of the government.
So they were basically the billing department for Medicare.
They were the administrative engine.
Hmm.
But by tasking private insurers with managing the flow of public money, the government created the internal infrastructure and normalized the presence of private, for-profit entities right inside the public system.
It was a subtle decision that had massive long-term consequences.
It created the very pathway that made the future marketization, the stealth privatization of Medicare, so much easier to execute down the line.
Okay, so we start with a system that's fragmented, inflationary by design, and already reliant on private middlemen. That really sets the stage for the next phase, which our sources call stealth privatization.
That's right.
This wasn't about repealing Medicare. Everyone knew that would be political suicide.
Oh, absolutely. The third rail of American politics.
Instead, it was about systematically destroying it from the inside out.
That's the pivotal strategy that really emerged in the 1990s. When Republicans, under figures like Newt Gingrich, gained control of Congress, they knew a frontal assault on Medicare would fail. So the strategy became, as Gingrich famously put it, to let the public system wither on the vine.
Wither on the vine. That is such a chilling phrase for a strategy targeting healthcare for the elderly. What did this systematic subversion actually involve?
It was a decades-long project with really three core elements. First, you systematically shrink the budget and the benefits of traditional Medicare to make it less appealing.
Okay.
Second, you heavily subsidize private insurance alternatives, and you make sure those private options look a lot better on paper.
And third,
You encourage beneficiaries to voluntarily abandon the public program for these shiny, subsidized private plans until the public system just rests. It naturally dies of attrition.
and the primary vehicle for this strategy, the real poster child for stealth privatization, is Medicare Advantage, or MA.
Yes, Medicare Advantage, which is sometimes called Part C. It was established through the 1997 Balanced Budget Act and then really cemented by the 2003 Medicare Modernization Act.
And it is the success story of this privatization project.
It absolutely is. The model is centered on a financial mechanism called capitation.
Okay, let's unpack capitation slowly for the listener because this is key.
It is the whole game. Capitation means the government pays a private insurer a fixed, predetermined amount of money per person per month to manage the complete care of that specific beneficiary.
So the money comes in every month whether the patient sees a doctor or not.
Right. It's like a prepaid health subscription.
It's like a gym membership. The insurer gets a flat fee for the whole year.
Exactly. And here is the critical point. If that insurance company spends less than that fixed capitation amount on the patient's actual care on doctors, tests, prescriptions, they keep the difference as pure profit.
But if they spend more, they lose money.
They lose money. This completely flips the traditional insurance model on its head.
Because traditional Medicare operates on a fee-for-service model. The government pays for the service that was rendered.
Correct.
But Medicare Advantage, with capitation, means the insurer is financially incentivized to minimize the services rendered.
That is the core structural shift, and it is so insidious. The insurer's profit motive is no longer tied to the quality or quantity of care. It is tied directly to reducing the provision of expensive care.
And it's been wildly successful.
Incredibly, today, over half of all Medicare recipients are enrolled in these private MA plans. It confirms that the wither on the vine strategy has largely succeeded in shifting control from public to private hands.
But here's what I don't get. If the government's goal in offering these private alternatives is supposedly to save money and increase efficiency, why are they paying private MA plans more than it costs to cover the same people in traditional Medicare? That makes no sense.
It sounds completely counterintuitive, but it's the secret to the insurer's astronomical profits. It's a structural overpayment mechanism.
An overpayment.
Data from MedPAC, the Medicare Payment Advisory Commission, consistently shows the federal government pays MA plans anywhere from 102% to as high as 114% more per person than it would cost for a comparable patient in the public traditional Medicare system.
So this is a direct subsidy to the private insurance industry.
It is. It's designed to incentivize their participation and to help them offer those extra benefits that lure beneficiaries away from the public program.
So they're already getting paid over 10% more than the public cost for the exact same patient, and yet they still find ways to extract even more government money.
Yes, primarily through a tactic known as upcoding.
Explain how this works, because it sounds like a very sophisticated way to game the system.
It is an aggressive, high-tech manipulation of the payment system. The mechanism is called risk adjustment. Medicare knows that treating a very sick person costs more than treating a healthy person, so they agree to pay insurers more for sicker, higher-risk patients.
Okay, that makes sense in theory. You should be compensated for taking on sicker patients.
But insurers engage in upcoding. They meticulously search through patient medical records and diagnostic codes, often using proprietary AI algorithms, to find any justification to record patients as having more severe or complex conditions than they actually have.
Can you give us a concrete example? How subtle is this?
Okay, think of it this way. An insurer takes a patient who has mild, non-complicated type 2 diabetes. Their algorithms might find a note somewhere that allows them to code that patient as having severe type 2 diabetes with chronic complications.
And that little change makes a big difference.
That seemingly minor change in the diagnostic code, that upcode, can trigger thousands of dollars in extra risk adjustment payments from the government per year. And it's all for profit. The patient's underlying health hasn't actually changed at all.
It's a mechanism to legally extract higher subsidies. And this is on top of something called the Quality Bonus Program abuse.
Precisely. The Affordable Care Act introduced a star rating system, the Quality Bonus Program, or QBP to reward plans for providing high-quality care.
Which sounds like a good idea.
It sounds great. But insurers have become experts at gaming this system too. They focus resources on meeting extremely easy-to-hit metrics, or they manipulate the data they report to secure these quality bonuses. The sources highlight that this results in billions of dollars in pure budget waste every year, siphoned off as profit instead of being used for better health outcomes.
This is just incredible. So MA plans are financially incentivized to over-report how sick their patients are to get government money, while at the same time, they're incentivized to undertreat them to keep that capitated fee.
That's the contradictory incentive structure.
So how do they keep their customers? If you're actively delaying or denying care, how do you not have a mass exodus from your plans?
They use a very sophisticated two-part strategy, cherry picking and lock-in.
Let's start with cherry picking.
To attract healthy seniors, the low-cost beneficiaries you want, MA plans, offer all these attractive supplemental benefits that traditional Medicare doesn't cover.
We see the ads all the time.
Yep.
Exactly. Dental, vision, hearing aids, gym memberships. These services are relatively cheap for the insurer to provide, but they act as powerful marketing bait for a healthy senior who isn't anticipating any major medical problems.
So they lure in the healthy, low-cost people with these extra perks. But what happens when that healthy person inevitably gets sick, when they develop a serious, high-cost condition?
That is where the lock-in and the denial mechanisms kick in.
How?
When a patient gets sick and needs expensive treatment, the MA plans deploy tactics like complex prior authorization processes. That means your doctor has to get permission from the insurance company before they can order a certain test or treatment.
And they have narrow networks of providers.
Very narrow networks. And these tools are used not necessarily to ensure the care is appropriate, but often just as a way to delay or outright deny high-cost necessary treatments.
So if a patient realizes they're trapped in a plan that won't approve their chemotherapy or their specialized surgery, they'll just try to leave and go back to traditional Medicare. They try. But that's when they hit the lock-in mechanism. That's when they hit the Medigap wall.
Medigap. Explain that.
Traditional Medicare only covers about 80% of costs. So almost everyone on it needs to buy a supplemental insurance policy called Medigap to cover the remaining 20%.
Okay.
If a senior leaves their MA plan after their initial enrollment period, they often lose the federal guarantee that they can buy a Medigap policy without medical underwriting.
Underwriting, meaning the Medigap insurance company can now look at their medical history.
Yes.
They can look at your new, expensive pre-existing conditions, like the cancer or the severe heart disease that your MA plan didn't want to treat, and they can either deny you coverage outright or charge you exorbitant, unaffordable rates.
Which effectively traps you.
It traps the now sick patient in the MA plan that's denying them care. Because the alternative is facing massive, unmanageable out-of-pocket costs on traditional Medicare, they're forced to stay and fight.
And this privatization strategy just keeps evolving. It's culminating in this newest model, which critics are calling backdoor privatization.
Yes, ACO REACH and its predecessor, direct contracting.
And this sounds even more alarming because it moves beyond voluntary enrollment.
It is alarming because it fundamentally targets traditional Medicare itself. These direct contracting entities, or DCEs, which were rebranded under the Biden administration as ACO REACH, can enroll traditional Medicare beneficiaries without their express knowledge or written consent.
Wait. I could be on the public program, traditional Medicare, and suddenly, without my signing a single piece of paper, my care is being managed by a private, for-profit company. How is that legal?
It's allowed through the administrative structure of the program. It automatically assigns patients to these entities if their primary care doctor decides to participate in one.
And the financial incentive is the same as Medicare Advantage.
It's identical, but arguably even more dangerous. These private entities get a fixed payment from the government, and they keep a share of the savings if they spend less than expected.
Which creates a powerful incentive for undertreatment.
A systemic incentive for undertreatment. Delaying tests, refusing referrals, discouraging expensive consultations. Critics argue that by automatically assigning beneficiaries to these private management structures, this model is fundamentally eroding the public nature of traditional Medicare through the back door, even for people who consciously chose to stay out of Medicare Advantage in the first place.
The pushback against all this, of course, has been the movement for comprehensive universal coverage, Medicare for All, or M4A. But for decades, these proposals have just hit a brick wall at the federal level. What is the fundamental obstacle they can't seem to overcome?
The obstacle isn't just, political gridlock. It is a highly integrated configuration of money and influence that policy analysts call the iron triangle of opposition.
The iron triangle. Who's in it?
It's formed by the three major sectors of the U.S. healthcare industry: private insurers, pharmaceutical companies, and the big hospital associations. And they lobby in near-perfect coordination.
And the amount of money they spend on this lobbying it's astronomical.
The numbers are staggering. They really represent the scale of the financial interests they're protecting. Just the major Medicare Advantage firms alone spent over $330 million on lobbying in 2024.
$330 million.
And AHIP, the American Health Insurance Plans, which is the main trade group for the industry, spent over $13 million in just one single quarter recently, specifically targeting any policy that would threaten their profits.
And that money doesn't just buy access to lawmakers, it fuels a whole information war against M4A.
A sophisticated multi-platform information war.
What are the tactics?
Well, they're twofold. First, they fund think tanks and commission research that is designed to produce these politically powerful reports claiming M4A would collapse the U.S. economy and create massive debt.
Okay.
And second, and maybe more visibly for you, the listener, they flood the airwaves with fear-based advertising.
We've all seen them.
Right. They're often aimed at seniors.
Yeah.
They use these very emotional slogans arguing the government will take away your doctor or you will lose your choice of hospital. It's all designed to drive public opinion against any reform that threatens the insurance industry's business model.
So with the federal level looking impossible, many activists have turned to the states hoping to create a successful blueprint there.
That's been the strategy for a while now.
But our sources show that progressive states like Vermont, California, and Colorado all tried these ambitious single-payer experiments, and all of them failed. What are the key lessons from those state-level failures?
They provide incredibly valuable lessons. They demonstrate that the barriers are structural, not just about political will. We have to look at the specific mechanism of failure in each case.
Okay, let's start with Vermont. Green Mountain Care in the early 2010s. It seemed like the perfect test case. A small, progressive state. What happened?
Vermont's attempt failed due to a fundamental problem known as fiscal shock. Governor Peter Shumlin, he championed the plan. But when the financial estimates for a statewide single-payer system came back, they were just politically untenable.
How bad were the numbers?
To finance Green Mountain Care, the state would have had to effectively double its entire annual budget.
Double it.
Which required implementing a massive new tax structure. Specifically, an 11.5% payroll tax on all businesses and a 9.5% income tax hike on residents.
Wow.
For a small state economy, the political and business leaders decided that was too massive a fiscal shock to absorb, even if the total amount spent on healthcare theoretically would have been lower than the premiums people were already paying.
So they abandoned the plan.
They did. It showed the immense political difficulty of trading hidden insurance premiums for transparent and very high taxes.
That's a huge lesson in public finance. But what about California? It has a massive economy, the 5th largest in the world, and almost total democratic political control.
Right. You'd think if anyone could do it, California could. But their CalCare attempts have also failed, most recently in 22 and 24, because of the sheer political cost and lobbying.
The cost was just too big.
Colossal. The estimate was around $400 billion a year for the state to take over all healthcare.
$400 billion.
And while proponents argued this would save money overall through reduced bureaucracy and negotiated drug prices, the required tax provisions needed to fund it were deemed politically impossible to pass.
What kind of opposition did they face in state?
The opposition was immediate and unified. The California Chamber of Commerce and other business groups led this powerful, well-funded campaign, branding the legislation a job killer that would destroy small businesses with new taxes.
And it worked.
It worked. Despite the Democratic supermajority, the necessary tax bills never even made it to a floor vote.
And then there's Colorado in 2016, which was a rejection directly by the voters themselves.
Correct. Colorado's initiative was put directly on the ballot, and it failed spectacularly. Over 79% of voters rejected it.
Why so decisively?
Well, that failure highlights the difficulty of gaining voter acceptance when those high tax increases are transparently linked to the proposal. But it was also complicated by controversy over associated policy issues, like the debate over guaranteeing abortion coverage, which drove additional organized opposition.
So these state failures weren't just about political will or tax aversion. They reveal a deeper, almost impenetrable legal barrier tied to a 1974 federal law, ERISA.
Yes. ERISA, the Employee Retirement Income Security Act of 1974, is perhaps the single most potent legal barrier to any state-level reform.
And why is that? What does it do?
It includes a critical provision that prevents states from regulating the health benefits, including the insurance plans that are provided by self-insured employers.
And why is that so significant for single-payer reform?
Because the largest companies in the U.S., your Amazons, your Walmarts, your big national corporations, they don't buy insurance from Blue Cross. They self-insure their employees.
Okay.
And under ERISA, those massive self-insured pools are federally protected from any state regulation.
So, if you're a state trying to build a single-payer system, ERISA legally prevents you from forcing the largest and often healthiest risk pools, the workers for the biggest employers, to join your new state pool.
Exactly. You can't achieve the necessary economies of scale or the cross-subsidization if the biggest, most financially viable group of workers is legally exempt. It basically guarantees any state-level system will face massive financial pressure from day one.
So given these overwhelming roadblocks, the Iron Triangle, tax resistance, ERISA, what are the two most discussed paths forward to try and bypass these barriers?
According to the sources, there are two main strategies. The first is a gradual incremental approach, lowering the eligibility age for traditional Medicare, maybe to 60 or 50.
Which leverages the existing popular framework of Medicare without the big tax fight.
Right. And the second, more radical path, the one that would enable true state-level innovation, is for Congress to pass an ERISA waiver.
A waiver that would essentially say, states, for this specific purpose, you are legally free to set up your own single-payer pools without federal interference.
Precisely. It would remove the single most important legal limitation that torpedoed all those earlier state attempts. It would make something like CalCare or Green Mountain Care potentially viable, though the political fight over the funding would obviously remain.
While that debate over universal care has stagnated, the process of dismantling the current public system has only accelerated. And that brings us to the pivotal moment of 2025. The signing of the One Big Beautiful Bill Act, OBBBA, on July 4th.
Yes.
Our sources describe this act as the most aggressive retrenchment in U.S. public health history. What was the core political driver behind this law?
The driving force was, to put it bluntly, purely fiscal engineering. The OBBBA was primarily focused on implementing massive tax reductions for corporations and high-wealth individuals, alongside some significant increases in defense spending.
And to pay for that, they had to cut somewhere.
To finance all that without the deficit exploding, the political consensus targeted the social safety net programs for colossal, unprecedented cuts. It was the culmination of that decades-long wither-on-the-vine strategy.
Let's look at the gutting of Medicaid, which serves the poorest Americans, children, people with disabilities. How significant are the cuts mandated by this act?
The cuts are historic. OBBA mandates slashing Medicaid funding by an estimated $900 billion to $1 trillion over the next decade. This is not trimming the edges. This is a fundamental tearing of the safety net.
And it's not just financial cuts. The act comes with new administrative barriers designed to kick people off the rolls.
That's the critical administrative mechanism. It mandates strict work requirements for Medicaid recipients.
And what's the projected impact of that?
The Congressional Budget Office estimates that this administrative hurdle alone will cause approximately 4.8 million people to lose their health coverage.
And the key here is the complexity, right? It's not just about forcing people to find jobs.
Not at all. The vast majority of people on Medicaid who can work are already working, often in multiple low-wage jobs. The problem is the punitive paperwork. They might lose their coverage, not because they're unemployed, but because they couldn't navigate a complex, constantly changing monthly reporting system to prove their eligibility. A missed deadline, a lost form, confusion over the documentation, and you're immediately dropped.
So it's a catastrophic loss of access through bureaucracy. And the OBBBA also directly attacks the Affordable Care Act, the ACA.
It does, by eroding its financial viability.
How?
Two main ways. First, it ends the enhanced premium tax credits, the enhanced APTC, which were expanded during the pandemic to make marketplace coverage much more affordable. Removing those will make insurance prohibitively expensive for millions of working-class families.
And second, it restricts a state funding mechanism called provider taxes.
Right. States rely on these provider taxes on hospitals or managed care organizations as a way to maximize their federal matching funds for Medicaid.
It's a way to draw down more federal money.
It is. And by restricting the federal government's willingness to match those funds, OBBA forces states into an impossible choice. Either drastically increase their own state taxes to cover the gap, or cut Medicaid eligibility and benefits even further. It's a strategic defunding of the entire public system.
And all of this accelerates the crisis facing Medicare itself, specifically the Hospital Insurance Trust Fund. This is the ticking time bomb.
This is the fiscal cliff. The HI Trust Fund, which is Medicare Part A that pays hospital bills, was already projected to become insolvent by 2036.
Due to demographics and costs?
Right. But the tax policies within OBBA significantly reduced the revenue flowing into that fund. And these policy changes are now projected to accelerate that insolvency deadline to around 2032.
So it moves the cliff 4 years closer. It pushes the crisis from a distant policy problem into an immediate, unavoidable threat. And insolvency doesn't mean the program just stops, right? It triggers a catastrophic legal requirement.
It triggers a sequester.
And we need to be very clear about what that is.
It's not a funding discussion. It's not a political debate. It is an automatic, non-negotiable legal hammer. The moment that HI Trust Fund balance hits zero, the law requires an immediate, automatic reduction, a sequester of all hospital provider payments.
How deep is that automatic cut?
The cut is estimated to be between 11% and 20% of all payments to hospitals. For a hospital, especially a safety net or rural hospital operating on a thin margin, a sudden cut of that size would be financially devastating.
It would lead to what?
It would lead to widespread financial distress and, critically, the likely rejection of Medicare patients by hospitals that can no longer afford to treat them at such a massive loss. This is the definition of the fiscal cliff scenario that OBBBA has put on a fast track.
So OBBA forces these massive cuts, accelerates Medicare's collapse. What do the sources project for the immediate public health crisis that would result? Let's start with scenario A, the direct human cost of this collapse.
The data on the human cost it's deeply alarming. The projections aren't hypothetical. They quantify a predictable public health disaster.
So first, a spike in the uninsured.
A massive spike. OBBA's policies are projected to create 10 million or more newly uninsured people by 2034. And when that safety net vanishes, access to care disappears and lives are lost.
And the research has actually quantified that loss of life in stark, almost unimaginable terms.
It has. Research from Yale Public Health specifically estimated that OBBA's coverage cuts and the subsequent erosion of access would cause between 42,500 and 51,000 preventable excess deaths annually.
Annually. Let's make sure everyone understands the scale of that number.
To put that into context, that annual death toll 42 to 51,000 preventable deaths is comparable to the total number of U.S. casualties suffered during the entire Vietnam War.
And this would happen every single year.
Every single year. not due to a new disease, but due to a lack of affordable access to necessary medical care.
So these tax cuts are, in a very real sense, financed by tens of thousands of preventable deaths.
That is the trade-off being made.
And what happens to the most vulnerable populations served by Medicaid? I'm thinking about maternal and infant health.
The collapse of Medicaid would be devastating there. Medicaid is the primary payer for childbirth in low-income communities. The massive cuts from OBBA would lead to a sharp, immediate rise in both maternal and infant mortality rates, reversing decades of progress.
And what about chronic diseases?
A full-blown crisis in chronic disease management. Diabetics unable to get affordable insulin, high blood pressure patients suffering strokes because they can't afford their medication, and a massive spike in emergency room visits for conditions that should have been managed easily and cheaply with primary care.
Okay, now let's turn to scenario B, the provider collapse and the economic fallout. If the payers Medicare and Medicaid disappear or slash payments, the providers have to disappear too.
It's an unavoidable economic domino effect. Rural hospitals are the canaries in the coal mine here.
Why them specifically?
They're already operating on razor-thin margins, and they rely so heavily on Medicaid it makes up anywhere from 20 to almost 60% of their revenue. An immediate, deep cut via sequestration guarantees mass closures across the country, creating vast medical deserts where emergency care, maternity services, any kind of specialty care is suddenly hours away for millions of Americans.
And what about the big safety net hospitals in our cities?
They will be completely overwhelmed. They already absorb the highest burden of uncompensated care, the cost of treating the uninsured. As that number of uninsured skyrockets by 10 million or more, these hospitals will face inevitable bankruptcy.
So their only option for survival is to change their mission.
The only option is conversion to an aggressive, for-profit model that cherry-picks patients and fundamentally abandons their public mission of caring for the poor.
And this collapse of the public provider network, it comes back to hurt the private market too, doesn't it? This isn't just a problem for the poor.
No, it hits everyone through a process known as cost shifting.
Cost shifting.
The surviving hospitals have to recover the massive financial losses from all the new uninsured patients and the deep government payment cuts. They don't just absorb those losses, they shift them. They drastically raise the negotiated rates they charge to private insurance companies.
Which means my insurance premiums through my job go way up.
Massive, unavoidable increases in private insurance premiums and employer healthcare costs. This ultimately harms corporate competitiveness on a national scale, and it suppresses wage growth for the average worker, because more and more of your potential raise is eaten up by the rising healthcare costs your employer has to pay.
This paints such a grim, detailed picture of total system collapse. Let's pivot to the counter scenario. What if the U.S. chose the cure instead? A comprehensive single-payer move toward Medicare for all.
The sources present M4A not just as a policy of moral or humanitarian necessity, but as a viable economic remedy, even with those massive upfront costs we talked about earlier.
So even though the tax numbers seem staggering, the system as a whole saves money.
Profoundly.
Right.
Research projects the M4A could save the nation somewhere between $450 billion and $650 billion annually compared to our current fragmented status quo.
$500 billion a year. Where do those massive savings come from?
They come primarily from two areas where our current labyrinth just hemorrhages money. First is streamlined administration.
Getting rid of the private insurance bureaucracy.
You eliminate the massive overhead, the complexity, the marketing costs, the executive bonuses associated with thousands of competing private insurance plans. And second, the federal government gains the singular, potent ability to negotiate drug prices.
Which it currently can't do for Medicare.
Right. The U.S. pays the highest pharmaceutical costs in the world. M4A would drastically lower these costs, often by 40% or more, just by having the government negotiate as a single buyer.
And what's the projected outcome for human health? Beyond the cost savings, what's the human benefit of universal access?
The projected human benefit is just as compelling. M4A is projected to save up to 68,000 lives annually, primarily by ensuring universal access to primary and preventive care. By removing the financial barriers that currently force people to ration pills or avoid the doctor, the system can pivot. It can go from reactive, crisis-based care in the expensive ER to a proactive, preventative care model. It shifts the entire focus of the healthcare system back towards health.
What an intensive deep dive. We started with this unstable, fragmented compromise back in 1965.
Right.
We watched as that compromise was systematically subverted by this aggressive, profitable project of stealth privatization.
Through Medicare Advantage and now ACO REACH.
And now we see that political project culminating in the existential threat posed by the OBBA.
The historical trajectory is just,
Yeah.
it's undeniable. The history of U.S. public health care is the story of this fragile public system that has been constantly under attack. That wither on the vine strategy has been a relentless, long-term political project to achieve full marketization by financially starving the public pillars until they collapse.
And OBBA is the tipping point.
OBBA pushes the entire system past that tipping point by accelerating the insolvency of Medicare and just ripping apart the Medicaid safety net, all to fund tax cuts.
And at the end of the day, the stakes here go so far beyond policy reports and budget numbers. The potential functional end of Medicare and Medicaid, it's not just a policy change. It represents a rupture of the American social contract.
That is the essential synthesis we have to take away from all this. It means accepting widespread class-based health inequity as normal. It means accepting a catastrophic, politically driven drop in our national life expectancy, a return to a fragmented survival-of-the-fittest approach to illness.
And we've seen in detail that incremental change lowering the Medicare age, small tweaks to the ACA, has consistently failed to overcome the overwhelming financial power of that iron triangle and the structural barriers like ERISA.
The status quo is collapsing under its own weight, its own complexity and exorbitant cost. We've analyzed how the political barriers to gradual change are immense, and the current path leads directly toward that documented catastrophe of more preventable deaths and severe economic fallout.
So the key question for you, the listener, to explore, the one that really builds on everything we've analyzed today, from the AMA's influence in 1965 to OBBA's sequester threat in 2032, is this.
Given the overwhelming financial and political power of the established healthcare status quo, is the ultimate choice for the U.S., now limited to one of two options. Either total system collapse, leading to unprecedented human cost, or an immediate big bang structural reform like Medicare for all. We've demonstrated that the historical middle ground, that path of incremental change, appears to be an illusion, a space that is actively being eroded by policy today.
Thank you for navigating this complex labyrinth with us. We hope this deep dive has given you the tools to understand the complexity, the history, and the ultimate stakes of this ongoing healthcare debate.